This episode of the Jerry Paul Podcast is CME eligible.
To claim credit, please go to the CME tab on jerrypal.org.
Welcome to the Jerry Paul Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
We are delighted to welcome back Corita Grudzen, who is an emergency medicine physician, researcher, and head of the Division of Supportive and Acute Care Services at Memorial Sloan Kettering Cancer Center. Corita, welcome back to the Jerry Paul Podcast.
Thank you.
And we're delighted to welcome Fernanda Bellolio, who is an emergency medicine physician and professor of emergency medicine at the Mayo Clinic. Fernanda, welcome to the Jerry Paul Podcast.
Thank you for having me.
And we're delighted to welcome Tammie Quest, long overdue. So delighted to have you, emergency medicine physician and palliative medicine physician and professor and director of the Emory Palliative Care Center. Tammie, welcome to Jerry Paul.
Thanks, friends.
So we got a lot to talk about. We're going to jump into a trial of a primary palliative care in the ED that, interestingly enough, did not show a difference in the outcomes that they were looking at. But before we jump into that, I think somebody has a song request for Alex.
I do have a song request. It's Another One Bites the Dust by Queen.
Why did you pick this song?
I like that the tempo that it has is around 110 beats per minute. And this is the range of recommended chest compressions during cardiopulmonary resuscitation or CPR. So that's why we asked for this song.
Okay, so it was not the fact that this was another primary palliative care.
No.
That bit the dust, another primary palliative care intervention.
No reflection on the trial.
Well, we'll get to the trial. Alex.
You can tell where the emergency physicians' minds were exactly with Fernanda, and we see where yours were. Okay.
All right. For the pre-recorded version, I set a metronome to 110. So I'm pretty sure I did okay there. We'll see how I do live here. Let's hear. Let's see. Steve walks warily down the street with the brim pulled way down low. Ain't no sound but the sound of his feet. Machine guns ready to go. Are you ready? Are you ready for this? Are you hanging on the edge of your seat? Out the doorway the bullets rip to the sound of the beat. Another one bites the dust. Another one bites the dust. And another one gone, and another one gone. Another one bites the dust.
That was great.
Did the patient survive the CPR, or is it too slow?
It usually doesn't work, no matter what you do. It usually
Especially in this population with a GAGMI of greater than 6. Yeah.
Depends on how long they were pre-hospital.
Okay, I'm going to start off with you, Corita. Back in what, May 2016, you published a randomized controlled trial, first author, palliative care in the ED, randomized study, cancer patients. Primary outcome was quality of life, and you improved quality of life. Why did you do another study of palliative care in the ED?
Yeah, great question. So that study was focused on patients admitted to the hospital. And as we know, palliative care, for the most part, is available Monday through Friday, 9 to 5. Luckily at MSK, we have palliative care 24/7, which is very unique. But so if someone got admitted, palliative care could see them the next day. I think that study was really important, especially I think the message that I give people is you can do something as simple as calling a consult and improve quality of life months later. So that's great. But what do we do about the majority of our patients who get discharged home? Most ERs admit, far fewer than 50% of their patients. And so how do we think about palliative care in those patients that go to observation and go home or just get discharged straight from the ER?
So that 2016 study was in the ED, but it was getting specialty palliative care to see them when they were hospitalized. Is that right?
Yep. They could have seen them in the ED or the next day upstairs. Yeah.
Okay. But that was a specialty palliative care study.
Mm-hmm.
Tammie, you've been doing emergency department work, palliative care work for a long time. Why do you think this was important? Like, what are the needs?
Yeah. So I would say that, 30 years, we've been in the palliative care space, not in emergency medicine, but we've been advancing the science in general palliative care for over 30 years and just plugging away with it, study after study after study, to build the field. And every study that we do in emergency medicine builds the field. I like to believe that we've come a long way since the support study in 1995. It was actually April 24th of 1995. It was published and had quote-unquote negative results. And that seemed to not stop us. It simply motivated us to keep going. And so
And for our listeners, because we've talked about support in the past, can you describe real quick, like in one sentence, can you do a one sentence support? Like what did they do?
So the one sentence of the support study was the largest randomized controlled clinical trial ever done at that time, funded by the Robert Wood Johnson Foundation, trying to have essentially a primary palliative care intervention of sorts, but a nurse-led intervention of trying to support palliative care course. And it turned out that actually it didn't work. That they put all this time and effort into it, and the outcomes that they had hoped for, better dying, less pain, didn't really happen. And so at the time, and I remember starting in this field very early on, that it was widely quoted and that it just led people to have in their gut that we knew there was something there, even though that study didn't show. And in their gut said, we need to keep going. And so many things were born after that. So it's probably not one sentence, but it's worth a good read for anybody in this field.
And Fernanda, so this was a primary palliative care study that we're going to be talking about. Why is that important in the emergency room?
So it's really important because we are the front door or the entry door, if you want to, from so many patients that come every day. And actually, our training as emergency physicians is mostly to resuscitate, to acute care. We talk about CPR rather than communication skills or end-of-life discussions. So this was actually something novel and new for so many of us. Probably not the 5 that we're in this room, but for I would say 90% of my colleagues, this was something new and novel and important, and it came at such a good time also that I guess we're going to talk about that later. But
yeah, well, let's dive into that. So this was a primary palliative care study. Corita, what did you do in this study?
So we were really building off the work that's been done for decades. So Tammie developed something called EPIC for emergency medicine, which is a curriculum that was one of the first ways that I think palliative care got spread in our community. And so we use that. We use Vital Talk. We adapted, a small group of us, Vital Talk for emergency medicine, which is communication skills training using simulation. I think most people who listen probably know. And then we had clinical decision support. And so we took all of those key pieces and audit and feedback and delivered them at the level of the ED. So it was a cluster randomized trial. We weren't randomizing providers or patients. It was really at the level of the ED across 33 EDs in random order. And then tried to see, if we could make a difference in healthcare utilization. Primarily, the primary outcome was admission to the hospital, acute care admission.
Why did you choose that as a primary outcome?
Well, in retrospect, it probably wasn't the best primary outcome, but it's a pragmatic trial. So in the end, we had almost 100,000 patients that were included in our analysis. So you have to have something that we could look at in claims. We weren't going to collect patient-reported outcomes from 100,000 people. It just, wasn't in the budget or the thoughts. And I think, we wanted something feasible, and we thought we could make a difference because that is the one decision we're responsible for, right? As emergency physicians, we either admit or we don't admit. That's completely up to us for the most part. And so I thought it was something within our control.
Can I ask just to unpack a little bit about the intervention itself? Mm-hmm. What is a clinical decision support? What does that mean, like in sort of practical terms?
So we used the electronic health record. I think in support, just going back to that trial, it really was kind of clinical decision support, but using paper. Mm-hmm. And so we did a similar intervention, but using electronic means. And so I think, there's been tons of clinical decision support trials that are negative and positive all over the place. But we felt like we want to give, like, the primary thing about clinical decision support is to give the provider information they don't already have. So we know these patients are really, really sick. That's not news to us, right? But what we don't know is, are they already on hospice? Do they have, documents in the record, like medical orders for life-sustaining treatment or a healthcare proxy? So we wanted to give emergency physicians that information, especially the hospice information, or if there were electronic, or other orders, and let them know about that right when the patient comes in. Because what we see is that some of the worst outcomes we have are when someone gets resuscitated because no one was there to explain. And it's very traumatic, obviously, for the family and all of that, and the team, really.
Mm-hmm. And did you have algorithms you'd present to them, like, given this patient's circumstance, these are recommendations?
No, it was rather simple. No. It was like, this patient is on hospice.
Okay.
Call the case manager to figure out how the patient ended up here. It was very simple. Now it was a pragmatic trial, so we let sites have some flexibility. So, we did have a clinical decision support pop-up that said, hey, this patient has serious illness. Why don't you go have a goals of care discussion? Everyone hated that, as you can imagine. Because one, they already know the patient's really, really sick, right? The emergency physician knows it's not new information. Number two, you're asking them to do something that maybe they don't have time. Maybe it's interrupting their work at the wrong time. I think I would actually ask Fernanda I know you guys had a particular clinical decision support alerts that popped up, and to talk about what you guys found the most useful, because you actually were part of the team and developed them at your sites.
So we had different response depending on the site, because also we had different resources in each one of the hospitals. So we have 2 hospitals that were community hospitals without palliative care or social work support. So it was the clinician working frontline in those community hospitals. And they found that they had no time. So even the alert would come, they found they have no time to go talk to the patients because they had to make many decisions with limited time. So they say, I think this is the best, and I will go a more paternalistic approach, will go this way. They actually hate the decision support coming, and they say, after the trial is done, we're done with this. We will stop and not have it anymore. Versus in our academic side that we're very well supported. We have palliative care. We have also social work, etc. We still have the decision support. But it's true what Corita was saying. When the alert comes, you're like, oh, yeah, I'm not surprised about the surprise question, yes, this is true. This is a patient that might not be here in a year. So I think we had different responses depending who was the user. So I don't think it's across the board that works for them.
And in addition to the clinical support, you did teaching, both didactics and communication teaching. Is that right?
Yeah. So the Epic for emergency medicine was asynchronous. So they could do that on their own, read all of that. And then Vital Talk, it was in the middle of the pandemic. So it started out face-to-face and then quickly moved to Zoom, which I know a lot of it's delivered that way now. But we had all of the APPs and docs do Vital Talk 4 hours. The course, they did the Epic EM and some other reviews they did that as a pre-read. And then we gave them audit and feedback on their performance after they started.
And also, what was the fidelity to the intervention at these sites? How many people actually did that?
We also did ELNEC. I think for all the nurses did ELNEC. So our benchmark was 75% of all nurses and 75% of the independent practitioners. And we reached that. There was one site we didn't, that was in the midst of the terrible pandemic, and there were a lot of traveling nurses. And so we just missed the nursing mark on one. And then we had a leadership transition. There was one ED where the docs didn't reach that. But I would say Fernanda was a perfect site PI and did very well at Mayo. But for the most part, we reached it across the board, and everyone got their clinical decision support.
So basically, everybody got the dose of the intervention, pretty much. And it was 29 EDs. Is that right?
Yes, we had. Yeah, it's a more complicated story. We had 2 pilots, and then there was. Yeah.
Okay.
A few bit the dust, so to speak.
I'm going to do really quick wonky because these confuse me all the time. This is a cluster randomized controlled trial and it's stepped wedge.
Yep.
What the heck does that mean again?
So step wedge means it's like a staircase, really, literally, and you roll out the intervention one step or one wedge at a time. You could do a cluster randomized trial that's you simultaneously run the intervention, right? You just flip a coin, each site gets the intervention or it doesn't. We decided to do step wedge because the intervention was so human resource intensive, and that's the Vital Talk part.
Yeah.
There were not at that time enough trainers to train 29 EDs worth of physicians and APPs at the same time, as you can imagine.
So ultimately, all 29 EDs got the intervention. It was randomized started at different time points in that ladder.
Exactly.
And the cluster randomization, am I right that you're not randomizing the people because there were like 100,000 people. You're randomizing the ED.
Yes.
To when they're going to start the intervention.
Yeah. And step wedge, I'll just say, has really fallen out of favor.
Oh, it has?
Yeah. So at the NIH Collaboratory, if you talk to the biostatisticians there, you should do everything at all costs. Did you just submit a grant using step wedge?
I just finished the step wedge not too long ago. I thought it was okay.
Yeah. So it is at this point, it is really a design of last resort only. And they tried to the Collaboratory, which is like the core pragmatic. They tried at all costs to be like, don't do it, don't do it.
Is that because, like, hypothetically, if there was let's say a global outbreak of some new virus, that a pre kind of post step wedge design may be influenced by that outcome?
Exactly. Yeah. You can control for time, which we did, but it's complicated. And the pandemic hit at exactly the same time as our intervention started. So it's not ideal.
So if you're looking at a site, like, they get randomized you see their hospitalization rates, and you randomize post, and that happens to coincide with randomizing that post intervention happens to coincide with COVID. It may be the COVID that's increasing hospitalization rate.
Exactly.
Yeah.
Exactly. Yes. And each site serves as its own control. Mm-hmm. So there is that, but most of our post-intervention visits occurred post-pandemic or during the pandemic, and most of our pre-intervention the vast majority occurred pre-pandemic. So as we know, like, everything changed. The patients coming in changed, admission rate changed, the resources in the community changed.
Like, for a while, hospices were very hard to get people into.
Nursing homes, whole host of it.
Let's just jump into the findings. Did this primary palliative care intervention in the emergency room involving 100,000 patients? Who were the patients again? Who were included? Had to be older than 66, right?
Yeah, so we use something called the Gagny score, which predicts short-term mortality. So they were at high risk of dying in the next 6 months.
Okay, so older adults, high risk of dying using the Gagny score, which includes...
And I think the Gagny score is like a comorbidity type score.
Yep, exactly. Yeah. It counts how many conditions you have. I think dementia has the most points and et cetera.
We'll have a link to it too, because it happens to be on ePrognosis.
I know.
So if you want to play around with that. And you excluded nursing home patients. Why did you exclude nursing home patients?
We felt like we couldn't make such of an impact. It wasn't like the intervention. It would have been a different intervention. Let's just put it that way. Like, we would have devised a different intervention.
Wait. Before we get to what did you find? Tammie, what do you think of this intervention? Like, is this like what you would have designed? I mean, is this ideal palliative care? Is it like the best you can do, given that it has to be feasible for, I don't know.
Yeah. So I have, so first of all, we keep saying 100,000 without like a celebratory, just really, chord or something here. So like,
Should we add that to special effects as our producer puts us together?
Every time we say 100,000, we need to like really go woo, right? Because I think that being able to have large cohorts that are prospectively collected in anything in emergency medicine, I would say that the only other thing that we have consistently that much data on is cardiac arrest. They're really, or maybe cardiac conditions like acute MI or stroke, but like that, it rises to a really high level. So I just want to start by saying anything that you can get almost 100,000 people in an emergency department study in is like incredibly remarkable. So let's just start there. The second piece I would say is that one of the tricky pieces, what I have done this a little bit differently. The one thing that we know is that education alone will not actually deliver behavior change. So if our behavior change is that we actually want an emergency clinician to do something, one of the really key steps is really adding an operational component to the study. So ensuring that, and that's really hard to do, by the way, with 29 emergency departments. Sure. And figuring out what that is. So for instance, would it have made a difference if, as a requirement in this study, every single emergency department who was eligible to be in the intervention had to have a relationship with a inpatient hospice for which discharge was immediately available to an emergency department? Let's just say that is one of the criteria, and that was part of what you had. That may be something that we could try in the future, for instance, right? But I think that hindsight is 2020. But at the time, and I remember kind of just when you're looking at scaling something, it can be really tough. So I think if there was only one thing in the design phase that I might have added to this, or for a future study, is to add an operational component to the intervention.
All right, we're dancing around the results. We got to say the results because we're kind of alluding to them. What did you find?
So there was no difference across every single outcome. Primary outcome, all of our secondary outcomes, they were remarkably the same.
So what were the primary outcome was hospitalizations, no difference.
No difference. No statistically significant. Admissions went down, but it was not significant. Revisits were the same. Home health was the same. Hospice was the same. Mortality was the same. Hospitalization, rehospitalization, all the same at 6 months.
Huh. So no difference. Go ahead, Alex.
Well, so Corita, maybe we can just go around. Corita, what did you think when you saw this?
I was not surprised at all.
Oh,
no.
Why?
No, I wasn't. Yeah, it was funny because our biostatistician was like so nervous to tell me. He thought I would be really upset. And I'm like, no, it's totally okay. We trained thousands of people. We trained literally thousands of nurses in ELNEC, hundreds, almost 1,000 physicians in Vital Talk. I mean, and I am certain, and we set up this clinical decision support, which at every health system is still up and running and identifying those patients. So do I think we improved care and improved communication? 100%. And that's what I care most about. So I don't.
Are you looking at any data on that? Can you look at any data since it was a pragmatic study?
We do. Yeah. Well, part of it is we looked at implementation outcomes fidelity to the function, not just the form, but we looked at reach. We did some qualitative. Those articles didn't get published in JAMA. So
they're out there.
Known journals. But we had qualitative, we had, things on the reach, effectiveness, all of that kind of those implementation outcomes that were all very positive. And I guess I'll hand it off to Fernanda, who can really speak to, I think, the fact that her clinical decision support is still up and running.
Well, before you jump into that answer, Fernanda, did it surprise you? Going to Alex's question. Or did you think same thing? I kind of expected that.
No, I don't know. I was hoping we will make a difference, but I was okay not seeing the data. And I'm a data person, but I was hoping that we can make a difference. I 100% agree with Corita that we felt our people were trained in communication, in goals of care, even in delivering bad news. That is things we were not trained before. So this actually was amazing how I could see my colleagues also go in and say, hey, I never thought this was so important, but it was so timely. Remember, this was March 2020, around that time when we got all this training. And we were having now these conversations really often. Remember that at the beginning of COVID pandemic, there was no treatment. the outcomes were really bad, like really high mortality. So we were actually having these conversations. It was, again, a perfect time. I remember my vice chair coming and saying, thank you so much for doing this training. It's amazing. And I'm like, well, don't thank me, but like, I'm glad this is the reception of the training.
Mm-hmm.
It was great and timely.
And in those other studies that were published, do we have data that it improved some outcomes, ability to have these discussions, or?
Yeah, I mean, that's what the qualitative data showed, the interviews with people, like the impact of the course, especially the Vital Talk, was really changed practice, for many. I think we know that, from everyone who's taken the course or has participated. Yeah. I mean, quality of, sometimes I think, okay, well, should we have looked at quality of communication? But I think everyone knows from Randy Curtis, who was always a true believer that like, don't use that as an outcome because it's always really high and you can't move it because it's already patients rate quality of communication so high.
And specifically, Randy Curtis's, he had a 2014 JAMA article on simulation, basically Vital Talk, right? For residents and nurse practitioners. Primary outcome was the quality of communication. No difference.
Yeah, and he warned me. So I was like, what should we do? He's like, don't use that as your primary outcome. But here I am, another negative trial. But yeah.
So I guess the bigger question, I'm going to turn to you, Tammie, on this is that we actually had Yale Shanker and Bob Arnold on to talk about primary palliative care intervention and oncology in infusion clinics. No difference in their primary outcome. The primary care intervention did not work. Well, I think we had some debate about whether it worked or not, but the primary outcome was negative. I can't think of another primary palliative care intervention off the top of my head that worked. We've done a nursing home palliative care and a primary care intervention study on our podcast. We'll have a link to in Europe with Leif van der
Woek, I think.
Van der Woek, negative. We'll have a link to that. Is this just a sign that
Vanden Block. Is this just a sign? Yes.
That primary palliative care doesn't work. We've had a lot of focus on advanced care planning. People saying advanced care planning doesn't work because the outcomes are the same. Maybe a qualitative data, we could see some differences. Should we be focused on primary palliative care too, saying we have no evidence that it works?
Big sigh.
I'm not ready to give up yet. So I will just, you haven't asked me.
Tell me why.
Yet,
what motivates you?
Well, yeah.
Okay, so
you
let
can
me
answer
tell
the
you,
surprise first by way of moving in.
Yeah. So I'm not surprised. I mean, so I think we should, have disappointment and surprise separated, right? So disappointment, yes, of course, right? And I know that, but surprise, no. And again, I'm really focused on the operational aspects of things. And part of, if you take an outcome like hospitalization, so we have good data that shows that for emergency clinicians, something like respiratory distress in a patient is the absolute most difficult thing that you will manage, gives you the most anxiety, and is most likely to lead to an admission. So unless you have, there are just certain things that people are going to complain of that I have to have an overwhelming sense of safety and care and knowing things are going to be okay to actually discharge a sick person who meets the score that you're talking about. I mean, I don't even want to discharge well people who have shortness of breath, let alone people who have uncontrolled pain or other things, or things that are bringing them into an emergency department and could have fragile caregivers and all sorts of things. So the nuance of trying to prevent hospitalization is so hard that for an emergency clinician, I think that's really a really hard one. I'll just go straight up from an emergent department. Now, if you looked at,
I would just have one caveat to that though, which is observation. So we did allow observation counted as remaining outpatient, right?
Oh.
So not every site had OBS, but I think OBS is a great counter to that, where you can have 24 to 48 hours of helping
And-
someone.
And let
Can
me
somebody
jump in
briefly
on
say
let me
what
jump
OBS
in
is?
on OBS. Can I jump in on OBS?
You got to
Yeah.
describe
Can you
it
just-
though.
Yeah, you gotta
Right.
just-
So let me do observation. So observation is often in an emergency department. It's a place where typically you're shooting for a 23-hour stay, but you can have up to 2 midnights or less than that. And it's highly protocolized. So most observation units, not all, but many in emergency departments are protocolized for common conditions seen in an emergency department that have a algorithmic workup, right? So GI bleed, TIA, chest pain, undifferentiated abdominal pain, things that you might need to observe for longer. What I will say that differs greatly depending on the hospital and the emergency department. And so many emergency departments actually you have to be low risk. Like the criteria to go into the OBS unit is that you're relatively low risk. And if there is a chance that you would be admitted, that you're encouraged to actually just go ahead and admit that patient. So part of it is in the 29 emergency departments, knowing that the observation criteria would allow for a patient likely as sick as the one in this trial is not a slam dunk. That you
And almost every ED has for many reasons, US News, Vizient, almost every ED, and there's some published literature, and we also saw this, has a pathway for hospice as part of OBS. We have one, like every patient that comes in with hospice goes to OBS, and NYU has one. Almost all of the health systems did have that.
Yes.
Okay.
It wasn't noted, but it's something to remember, right? If you take
Absolutely
general emergency departments, or if say you generalize this to community, EDs,
community
it may or may not. That may or may not work. So in any case, I'm not surprised. It's a hard outcome in sick people. Let's just put it that way. It's a hard outcome. Now, some of the other secondary things, you may have seen if it was trigger of specialty palliative care consultations. I mean, basically the things that we saw in 2016, leveraged. I mean, maybe I might have expected more, but I think a primary outcome of hospitalization is just a very hard primary outcome.
So let me ask you this, is that, I'm trying to imagine another study like primary cardiology intervention in the emergency room. You do teaching, you do some didactics.
We're doing that right now, Eric. We're doing an 80-site trial right now.
Right? You do this primary cardiology to improve SD elevation MI outcomes, but it's okay if you don't have any interventional cardiologists or cardiologists in the group, right?
We did that. So we've done that. And I mean, I hear there's more, but the observation unit actually was the solution early on in palliative in emergency medicine. The observation unit was essentially built for patients with chest pain. Like in fact, we used to call them chest pain units.
But I'm trying to do the analogy here. It's like this study did not push for specialty level palliative care involvement.
No, that was absolutely not the recommendation. And in fact,
should it have?
A lot of people,
like in a cardiology SD elevation MI study, you probably have specialty cardiology involved, right?
No, it was an option. So part of the clinical decision support for complex patients, one of the recommendations was, order palliative care consult. Absolutely.
Did they use it more often in the?
We didn't look because I wasn't I'm sure they did, but it wasn't the focus and it wasn't the an outcome of interest, just because, there was clear feedback from the sites. We met as obviously with all the palliative care teams as well at all these health systems, and there's no way they could have handled the increase in volume that if we had consulted them on every patient. And that would not have changed the outcome, because we're trying to get people home, not waiting for palliative care. At MSK, we can get palliative care.
So it may not change the primary outcome of hospitalization because they would have been hospitalized, but may have changed. Fernanda, what do you think? Would it have changed potentially utilization rates, like hospice utilization?
So it's interesting question, and I know you're challenging a bit here, as Eric. We do have now our our palliative specialists do try. At some point, we did like a pilot trying to go and come to the ED when needed. Initially, they were worried what's going to be the volume, because also they're really busy in the hospital. So I'm going to be called every 20 minutes to go to the ER. Like, are the basic conversations something that the emergency physician should be able to happen? Like, at what point do we come in? What's kind of from their perspective? So we try a pilot, although there was some concern about what numbers we will get. I'll tell you, we don't have it anymore. So it wasn't because we didn't try.
Yeah.
It just felt like the patient that had a palliative need for a specialist in the ED was not the same one that we wanted to include. We had to talk to a lot more patients than the ones that needed really that specialist care.
Yeah.
Even if we had 1,000 palliative specialists that could come to the ED, it might not be the best resource at this point.
It's such a difficult nut to crack. Like, on the one hand, we have, taking a step back, as Eric was saying, there are many primary palliative care interventions that have not been, they've been sort of negative trials, or, however you want to characterize it. They have not had
They've been negative. They've been
primary
negative
outcomes. Yeah.
But are you surprised though, when especially palliative care, you're having people that they believe in the mission, they have chosen this field, they're doing an extra year of training, versus you have a captive audience versus people that didn't sign up for this, were not paying them to do this, they didn't want to do a fellowship. It's like a completely different, and there is some evidence also, which is because obviously I looked up and I've talked to Yael about primary palliative care, and I think we need to have an R13 or some conference on primary palliative care to figure out, can we move this field forward? Most of the interventions have been with nursing. It's very interesting, as opposed to independent practitioners. So it's comparing very different things, if that makes sense. In ours, we did train physicians, but most of the primary palliative care literature is in nursing.
Right. So that was an important advance. And as Eric has said many times on this podcast, we learn as much from what studies that are negative about what doesn't work as we do from studies that are positive about what does work. And so it's equally valuable. This was our first, one of the first glimpses into training clinicians in palliative care principles. Also was negative for just about everything you looked at. Tammie, I see you want to jump in.
So one thing that, so if you look at the very earliest interventions in palliative care in the emergency department, so one of the reasons that Corita's work is so valuable, no matter what the outcome, is that she assigned more rigorous methodology. But actually, if you look at the ED literature, was built on very small one-site studies where you would have this small thing happen, or in this one ED, you'd have one nurse or one training or one something or another. And early on in the field, we actually, and those were what I would consider to be primary palliative care interventions. They are not at the level, they've not all been scaled and replicated at the level of this particular intervention, though I will say the whole field was founded on small primary palliative care interventions because there wasn't anybody else and nobody was in the emergency department. And so some of the earliest embedding were not people that were really subspecialty trained. They were people who had an interest and an engagement and an operational focus to make this happen. And so, because you remember, board certification didn't come around until 2007. And at that time, we had maybe 10, 25 people. So if you look at anything pre-2009, 7 or 9 in emergency medicine, anything that was published as an intervention was essentially a primary palliative care intervention. So I will say that if you dig back into the literature and history telling us, going back and digging through some of those things and trying to amplify that into randomized controlled clinical trials, apparently not step wedge, per Corita, because we're never doing that again. But, if we never do that again, but we go back and dig and look at all the nuggets of things, I'm just not ready to give up yet. Now, what I will say, because here's
and you're not ready to give up on primary palliative
Primary
care.
palliative care.
That's right.
in
I'm
the
not
ED
ready to give up on
Just for the record, no way.
Yeah.
I'm not ready
Well,
either.
because here's the other deal. Well, what we didn't do when we improved cardiac outcomes in an emergency department and stroke outcomes, we did not make emergency physicians necessarily go do neuro fellowships. They can't do them. Nor did we make them do cardiology fellowships.
Yeah.
They can't do them. What we did was we trained systematically every emergency physician in this country that becomes board eligible, has core competencies back to residency. And we married that to clear operations and handoffs and algorithms and
time limits, right?
and time limits.
Within X minutes.
Exactly. We put a time limit. So we have seen common serious problems being managed in an emergency department effectively with better outcomes when we put all of those things around it.
Let me ask you this, then moving forward, if you had to design the next study about primary palliative care in the ED, what would that look like? Based on what you've learned from this study.
Let's go to Tammie first because she has to leave in 3 minutes.
Okay. I'd add an operational component.
Can you give me an idea what that looked like?
So I think that, hard discharge outcomes, maybe not even OBS. I mean, because that's a little bit, sneaky because they still have to go someplace. But I would have a hard community operational component, which is a place for them to go or be that is safe. And so that is, hospice is one of those things.
Yeah.
And the second thing that I would do is you'd have to tailor it to each individual emergency department because you couldn't, this is what gets to be complicated for standardization. But the case management model, the social work model that exists in an emergency department that makes disposition happen in some places, trying to add that in. So I think those are kind of operational components because the emergency physician's core stress always is, I don't have to do that, but now what do you want me to do? And there's got to be something else.
Fernanda, what would you do?
Well, maybe creating TV shows that, despite realistic expectations of what's happening after they visit.
That's great. So outcomes of CPR are not most people survive.
Yeah, the James Tulsky paper, Miracles and Misinformation on TV in New England Journal. Yeah.
Okay, Corita, what would you do? What's the next for you?
I agree with Tammie. I think, it's all about the resources and the place you can, and that was something we couldn't control. It's like outside of our control other than observation. We can't force a hospice, getting GIP approved for most of our patients is almost impossible. So even if you have home hospice coming, it's like still doesn't feel safe enough. And so
you need caregivers to consent, which is tricky.
Yep.
Well, let me ask you this. Let me ask you this, Corita. And Fernanda too, what if your intervention worked really well? There were amazing goals of care discussions, and it turns out people wanted to be hospitalized. People didn't want to go back home. They weren't ready for hospice. They wanted to have more interventions. What if it worked? And the outcomes... I think
that would contradict decades of literature about what people want when time is short, but that would be interesting. Yeah, that would be a complete reversal of everything we know about what most people want. I mean, we know
I will say, Corita, in this study, the people that died, I think it was on average was like 17 days, right? Is that so? These were people very close to the end.
These are pretty sick
if you look
people.
At that, right?
So this would be consistent with past literature that Tammie, I know you got to go. Thank you for joining us.
We'll keep going. With
awesome.
This would be consistent with past literature is if you bring up goals of care conversations, you're not forcing people, but turns out most people don't want default of medicine, which is very aggressive care at the end of life.
Yeah. So, when time is short.
Time is short.
Yeah.
The prognosis piece is key.
Go ahead, Fernanda.
Trying to answer your question, really just having that small conversation initiated in the ED, even if they're not ready to make that decision yet, gets them thinking, okay, they talk about goals of care. What do I mean? What are my goals of care? Amazing how many patients come to the ED have never even thought about this, despite being on palliative chemotherapies, etc. So it really, you put that seed on them. Yeah. I agree. They might want to be admitted. They're not ready to have a more, like an outpatient treatment at that point. But you are putting that seed, and that really makes a big difference for the admitting team too. And I think passing on that baton to the team upstairs, if they're going to come in, is so important too. And it's part of why we're still having the BPAs, or like the clinical decision support tools that Corita mentioned in the hospital, because it helps even if they are not dismissed. So I agree with you. Not because they come in is
Fernanda, let me ask both of you. I'm going to start with you, Fernanda. So we're going to end with another one bites the dust.
Wait, before you introduce that, hold on. I want to just say one thing, which is also, I want to say, I think there has been culture change in the emergency department. One of my first studies was called, Am I Doing the Right Thing?
I know. I quote you. I cite that all the time.
Thank you. Like, emergency medicine providers, they want to do the right thing, and yet they often don't have the skills, the training, the knowledge to do the right thing, or to know what the right thing to do is. And so I think that is changing over time. And Fernanda's talked about how that's maybe changed more in academic centers than community settings, but I think it will continue to change. And in our palliative medicine program, like, majority of fellows who match next year are emergency medicine trained. It's like, whoa, what's happening? Wow. We've had at least one emergency medicine trainee like every year in our fellowship for several years now. There's movement here. So I just want to note that as well. Okay, Eric, go ahead.
All right.
Back to you.
Is this another study that bites the dust? Would you consider this a negative study, Fernanda? A negative study of primary palliative care?
I think we learned a lot from this study, and we're better because of it.
Great. Corita, how would you answer that question?
I don't know. It was a negative trial, absolutely. But I think, the wonderful thing, and I always tell people about pragmatic trials, is you're implementing interventions that have already been shown to work. So you are changing care for the better the first day you start the study, because we know these things, in isolation work fantastically, maybe not in the outcome we looked at. So I think, to me, that's a win from the beginning, before you even look at the results. So it's a negative trial.
I'm going to push you on that. Do we know these individual things really work in big randomized control study? Like, I don't know. Does communication education, has that been shown to work? I want to apply the same principles that we're having discussion around advanced care planning. Does it work or not? To some of these things. Doing didactics for 4 hours, does that really work? I love this study. Because I think it does give us information. Maybe we need more, just like Tammie said. You can teach people all you want, but if you don't change the system, you're going to get the exact same results.
I don't think it changes disposition in the emergency department. I think it has profound impact on moral distress for the emergency. And we have a lot of qualitative data. It decreases moral distress. It increases satisfaction with your work. I'm certain it improves communication in certain scenarios. And there's lots of literature on ELNEC and EPIC EM, like smaller, they're not RCTs, but we know Vital Talk. Otherwise, we wouldn't have people flocking to the courses. I think they're really impactful. So not in disposition from the ED, but in other ways.
Wonderful. Well, Corita, Fernanda, thanks you for joining us. And thank you, Tammie, who's no longer with us. She had to run off to another meeting. But before we end, Alex, a little bit more of Another One Bites the Dust.
Another one bites the dust. Another one bites the dust. And another one gone, and another one gone. Another one bites the dust.
Wonderful. Corita, Fernanda, and Tammie, thank you for joining us on this Jerry Pal podcast.
Thank you so much for having us.
Thank you for having us.
And thank you to all of our listeners for your continued support. And we'd like to send a special thank you to all of the donors who've donated more than $250, including
Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordowski, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, and Paul Amatelli.
Thank you very much for your support.